So hello everyone, we're live. Are we live? There was slight lag, I think. So hello, good afternoon. I don't know how many of you would be here right now because it's mid-afternoon, but we had to do the recalls. Just a very, very short discussion of the questions that came yesterday. As always, for every recall, I'm quite happy to say that all the questions that came in the exam were from what we have studied in the regular classes, in the rapid revisions, in the MIQ sessions. A lot of questions similar because these are all important questions that we discussed. So yes, a lot of those questions did come in the exam. But I say that they have rephrased the questions, they have turned and twisted the questions. These are all PYQs, these are all PYTs, but they don't look like that. They look different. So for those students who just tend to read the question answers and go, who have not gone through the text, for those this paper could have been moderately difficult, because if you're only reading the PYQs, not the PYTs, then this question paper is tough because questions are not the same questions that are asked every year. Topics are the same. The crux of the question is the same, but the way it has been asked is very different from all the times. So I would say this was a moderately tough paper despite the topics. Is there a lag? Is there any lag? Tech team, are we sure there is no lag? I'm not able to go through the live chat. What would you call it? Would you call it a moderate paper? Would you call it a moderate paper? Just let me. No lag. Okay, I don't know why I'm seeing the lag. Good afternoon, everyone. So sorry for the delay because I'm not able to make out if there is a lag or not. But anyway, I hope your paper went well. So let's start with the recalls. This was a tough paper. I wouldn't call it easy. I wouldn't call it moderate. Also, I would call it moderate to tough. That is what I would be calling this paper. So anyway, let's start with the discussion. So what is the answer that you marked to all of these? Tell me if there is anything that you might have encountered different in the paper, there is any change in text, please let me know. A 17-year-old boy with moderate to severe nodulocystic acne is scheduled to begin treatment with oral isotretinoin. Which of the following baseline investigations should be obtained before initiating therapy? Okay? So This is a question that is already telling us the diagnosis. It's telling us that the patient suffered from acne. He has to start treatment with isotretinoin. So that part of the job is done. It has told you the diagnosis. It has told you the treatment. Now it is asking which of the following baseline investigations should be obtained before initiating therapy. This exact question was there in the INI RDX, which I just did in April 2026, because a question like this was expected. Then I also discussed it in the MIQ FMGE. I discussed it in the CPR that these are the investigations that you have to do before starting treatment. So isotretinoin is a oral retinoid, and when it is a oral retinoid, it tends to affect the liver. It tends to affect your lipids in the livers. It can increase your liver enzymes. There can be a mild hepatitis, so your AST/ALT can be increased. In the lipids, it tends to increase the triglycerides. There can be hypertriglyceridemia. So what we do is a test at baseline, and then we do a test at about 3 months of in treatment, and then we can repeat it at 6 months. We can repeat it at 9 months. So this is the kind of testing that is required when the patient is on isotretinoin. CBC not done, lipid profile is done, ESR not done, CBC not done, LFT is done, but serum electrolytes is not done. So what is the correct answer? The correct answer is LFT and lipid profile. So this is a very just quick revision. This I always tell you that a nodulocystic acne patient has to be given isotretinoin, which is a relatively high dose of 1 mg per kg per day. You have to remember that it is teratogenic. UPT has to be done. So the investigations that have to be done before treatment. In a female, you will do UPT, especially if she is married. In the Western countries, they will do it in the unmarried girls also. But in India, we have to do it for the married females. And then we have to do their LFTs. We have to do their lipid profile. So these are the tests that we have to do before and during treatment of acne. Next question. A 24-year-old woman presents with a slowly progressive, linear, depressed, indurated plaque over the forehead extending into the scalp. Examination reveals localized scarring alopecia over the involved area. What is the diagnosis? So I am sure all of those who have sitting in the regular classes, who've sat through the rapid revisions would know this. But what is the problem with this question? Problem with the question is that there is no image. If I keep the image in front of you all, it will become very easy, because that's an image you all know, where there is a depressed scar running from the forehead to the scalp, and there is alopecia on the scalp. So as an image, you all know it. But for those who only know the image, who have never actually seen what the disease is, what happens in the disease, for them, this question is difficult, because the trend in the papers is changing. They are not asking you as much images. They are asking you description of the lesions, because they want to know whether you have read it or not. They just don't want to see if you've turned through pages of important images. That has completely changed over the last 3 years with all papers, whether it is FMG, whether it is INI, and see so many such questions in the paper this time as well. So when it is a linear depressed plaque extending from the forehead to the scalp, and there is alopecia over the scalp, what do you think is the correct answer? What do you think is the correct answer? Tell me, is this linear lichen planus? Linear lichen planus would be violaceous lesions, and it will not be indurated. It will not be indurated. Indurated means firm to touch. Encoop D. Saber is another name for linear morphia. Alopecia areata is not scarring at all, so this will not be there. DLE would have discoid lesions. These will be discoid or round lesions. There would be scaling, telangiectasias on these lesions, marginal brown pigmentation. So this is not DLE. What is that disease where you have linear depressed indurated plaque extending from the forehead to the scalp? That is Encoop D. Saber. That is linear morphia. A question on morphia was asked in the NEET PG 2024, and that is when I had said that this can be asked in the FMG paper also, because it tends to mirror the NEET PG papers over the last few years. So see, they asked morphia, they have asked morphia here also. This is the NCOOP D Saber, which is the linear morphia. This is a depressed, indurated. Indurated means firm. Here it is firm because there is fibrosis in the skin. It's all collagen. So this is firm. So this will start from the forehead. It will go into the scalp. It looks like a sword scar. You know, Gajni, I always say remember Gajni when you have to remember linear morphia. Because of the sword scar appearance, this is called as Enkubdi Sabre. Kubre means fight. Sabre means sword. So it's as if you have gotten a scar due to a sword fight. So this is Enkubdi Sabre. A very expected question, you know. FMG is also going back to the older questions. This used to be asked back in 2015-16, and now suddenly after 10 years they've asked it. Marjolaine ulcer, then a few other questions, they are now coming back. So you should be seeing papers a little longer back also. A 68-year-old male, so this is an old elderly male, presents with a 6 mm pearly nodular lesion with rolled borders, surface telangiectasias located at the medial canthus of the eye. So reading just this much question, this is a long one. Let us see. This is 6 mm. This is pearly. Pearly means it is shiny, nodular lesion with rolled borders and surface telangiectasias. Wherever you read the term rolled borders, you have to think of BCC. And the question next also tells us that this is BCC. So that job is done. We have the diagnosis. So if we have the diagnosis, what next now? This lesion is classified as high risk. Although the lesion is small, what is the reason for classification into high risk? My God. So they have gone one step aage. They used to ask BCC, they used to, you know, give you description of histopath of BCC, and they will ask you certain questions related to treatment. But now this is the next step. What is the reason for this classification to high risk? Increased likelihood of locally aggressive invasion into adjacent orbital structures, high propensity for early regional lymph node metastasis, greater risk of hematogenous spread, frequent intracranial metastasis through direct vascular dissemination. So first of all, mark the question, the options that are wrong. BCC does not enter the blood vessels like this. There is no hematogenous dissemination. Yes, it's a locally aggressive tumor, but it does not metastasize as easily. The risk of metastasis is less than 1%. And if at all that happens, that is always lymphatic. There is no direct dissemination. So this is out, this is out. Okay? These two things are out. Now, high propensity for early regional lymph node metastasis. BCCs, I told you, do not metastasize. So there will be no such BCC which will have a tendency to metastasize easily. That does not happen. That's a rare thing. Increased likelihood of local aggressive invasion, that always can happen with BCC. So this is the correct answer. There can be a locally aggressive invasion, not metastasis, not vascular dissemination. So you have to read the options carefully. And in order to make sense of this, again, this question demands that you know your text, you know your basics of BCC well, not just superficial knowledge. So this is BCC. This is a slide that we always see in the classes. You will have this typical shiny nodular lesion with rolled out borders, telangiectasias. It can be pigmented, it can be ulcerative, but the diagnosis of BCC is very simple with these few terms of rolled out borders and telangiectasias. That's out. The question is telling us BCC, but it is now going to the next level. That is the treatment of BCC. We can do a medical management. We can do a surgical management. Okay? In the surgical management, a wide local excision is done where some margin has to be kept, or we can do most micrographic surgery. So the question here is asking us, how do we classify the risk? Before we classify the risk, I will tell you that whenever we have to do a surgical excision of BCC, we see what are the areas where the BCC is present. So there are three different zones with BCC: L, M, H, which is low risk zone, M is medium risk zone, H is high risk zones. So this is a new thing. that I am telling you here. These zones guide in determining the recommended surgical margin. What is the criteria for doing which surgery we choose, whether we are doing the standard wide local excision or we are doing the Mohs micrographic surgery. Now, low risk areas will obviously be the areas which are trunk extremities. There is a good chance that the BCC here will be low risk. You can easily take it out and there will be no metastasis. In the medium risk areas for local invasion, for aggressive invasion into surrounding tissues, medium risk are cheeks, forehead, scalp. Basically, your face and your chin. Here, even the margin is very difficult to take because the tissue is not as much. High risk are the mask areas of the face. You have the central face, the nose, the eyelid, the eyebrows, the lips, the ear, the temples, as well as the hand face areas. So these are your high risk areas. This is a very new thing that I'm telling you about BCC. So please make it a point to know that these are the zones which help us in deciding what is the risk area of BCC. And according to different other parameters, again, we can classify into low risk and high risk. Now, what are these? Low risk is if it is localized, a small lesion in the L area, or if it is a very small lesion in the M area. But if it is in the high risk area, whatever is the size, it will always be high risk. So what was the medial canthus of the eye? Medial canthus of the eye was H area. It's a high risk area. So just look here, this area H, where in our case the lesion is on the medial canthus. It is 6 mm, that doesn't matter. The size doesn't matter. The area is H, it is the high risk area. Then if it is poorly defined borders, it's a recurrent lesion, patient is immunosuppressed, there is a previous radiation in that area, it's an aggressive cancer, if it involves the nerves. So these are all parameters based upon which we can call a BCC high risk. In our question, it is the area which is determining what we call it. So this is a high risk area because there is a chance of it invading into the localized orbital structures. Even if you don't know all this classification, even if you don't know the LMH zones, you can still just use a little bit of your, thinking and decide why a lesion present just below the eye is high risk, because there is a chance of localized aggressive invasion into the orbital areas. So this is a question which, yes, even if you don't know technically, you can use your common sense and come to the answers. That is what you have to use when you are, doing the papers. You have to use the common sense if you don't know the answers. That comes in very, very handy. Now, coming to this question, we'll make it a little faster from here because all of these are infections now. Infections is very, very simple, very expected. None of the questions here are out of normal. 35-year-old man presents with well-defined asymptomatic brownish patch over the groin that has gradually increased in size over the past 3 months. No itching, no pain. Wood's lamp examination reveals a coral red fluorescence. What else would they do for you? They've told you that the lesion is asymptomatic. They have told you that there is coral red fluorescence. There is no itching. They have given you an image which is showing you the coral red fluorescence in the folds. What else do you need for diagnosis? Yes, I know that all of you know that this is erythrasma. What causes erythrasma? It's a commensal which lives on my skin, your skin, but in certain situations it can cause disease. This is Corynebacterium minutissimum. So what is the diagnosis? Diagnosis is erythrasma. It is caused by Corynebacterium. Bacterium means bacterium. So what do you have to do in the treatment? You have to give antibiotics. You have to give treatment that will kill the Corynebacteria. Will fluconazole do it? No. Fluconazole you could have marked for tinea, but tinea would be itchy. Tinea would be red. It will not be a brownish lesion and it will not have coral red fluorescence. Permethrin is again for scabies. Scabies would be itchy papules, not cilia. Topical steroid, absolutely not. This is not psoriasis. This is not any other disease. So no steroids here. What we will be giving is oral erythromycin because that is what we do for erythrasma. So this image, I always tell you, is a very classic image that can be asked. This coral red fluorescence, often repeated question. Last year also it was there. Now also it is there. Just remember, it is a bacterial disease, so we have to treat it with antibiotics. A man presents with intense itching, especially at night, lesions over the scrotum. He lives in a crowded environment. Clinical image is shown below. What is the primary lesion of the disease? Another question that's very, very, very expected. Scabies, that's always going to be asked. What is the hint? First of all, it is itchy. Itching is more at night. So this is the most important hint that you can get in any question, which is nocturnal itching or a nocturnal exacerbation of the itching. Crowded environment again takes you to scabies, nothing specific here. Lesions can be on the scrotum, that's a part of the circle of febrile distribution. But what is the unique thing about scrotum? On the scrotum, what we have are these nodular lesions. So nodular lesions of scabies are on the scrotum. Anyway, they are not asking us that. They are asking what is the primary lesion of the disease. Papules are seen, but this is not a primary lesion. Vesicles are seen in infantile scabies, but this is not a primary lesion. Nodules we see in the photo, but this is not the primary lesion. What is the primary lesion of scabies? That is the burrow, the tunnel in which the mite lives. So please remember, initially they have asked this question for acne, that you will see papules, pustules on the photo, but what is the primary lesion? Primary lesion is comedon. Here, see, they have given you the whole scenario of scabies, but they have asked you what is the primary lesion? Primary lesion is a burrow. So even though in the photo you see nodules, you may see papules, but remember the primary lesion is always going to be a burrow. That, you see, all of this can be seen, but primary lesion will always be a burrow. These are small wavy tunnels, especially in the finger webs where the mite lives. If they have to give you a photo, they will give you a photo of infantile scabies, like it was asked in the January 26 paper. You will get these vesiculopustular lesions on the palms and soles, or they will give you an image of genital scabies, like they gave it here, where there will be itchy persistent nodules on the scrotum. Remember, treatment of choice is 5% permethrin. Then this question, a 42-year-old man with borderline leprosy has been receiving multi-drug therapy for the past 3 months. So this is a patient who is already diagnosed as leprosy, is already on treatment for 3 months. Now he presents with sudden edema of the existing skin lesions, along with pain and tenderness of the ulnar nerve. So what he has is erythema and edema over the pre-existing skin lesions, plus pain and tenderness of the ulnar nerve, which means he is suffering from neuritis. So there is a type 1 reaction happening, and along with the type 1 reaction, there is neuritis happening. So we know what is happening in the paper. Let us see what it is asking. What is the appropriate modification or change to his treatment? Discontinue MDT, start systemic steroids? Absolutely not. A similar question was asked last year. Similar questions are asked in the NEET PG and the INI-CT. Please remember, we never discontinue MDT. So this is out. Stop MDT out. These two are out. Now coming to option C, continue MDT, add thalidomide. Why will I add thalidomide? First of all, this is type 1 reaction. Second of all, even if it was type 2, thalidomide is not the drug of choice for type 2 also. What you are instead going to do is you are going to continue MDT and add systemic steroids, which will tackle the reaction, which will tackle the neuritis. Correct answer here is option B, that is continue MDT and start steroids. So see, whatever reaction they give, whether they give type 1, whether they give type 2, you have to remember that it's always continuing MDT and starting steroids. Whether type 1 or type 2, you will not even mark thalidomide, because that is not the drug of choice, not even for type 2. So correct answer here is start steroids and add that to the MDT. Don't stop MDT. Question number 8, as expected, leprosy. 3 questions from leprosy. That's very, very, very expected from the paper. A 28-year-old woman in her second trimester of pregnancy is diagnosed with multibacillary leprosy following slit skin smear examination. Which of the following is the most appropriate treatment? So this is a patient of leprosy. She has already been diagnosed with leprosy, but what is the catch? Catch is that she is pregnant. So the question here is asking us that whether we can give MDT in pregnancy or not. Please remember, there is no way you are going to defer treatment till delivery. It is very important to treat the infection. You do not give rifampicin monotherapy ever. You do not give dapsone monotherapy ever. So these are out anyway. Such treatments don't exist. What you would rather do is just give her standard NDT, because you have to assess the risk benefit ratio. Here, the benefits of treating the infection are much more than the risk, if at all, to the baby, which is negligible. So the correct answer here is the standard multi-drug therapy that is given. Another question on leprosy, and a very long one. A 30-year-old man presents with 3 well-defined hypopigmented patches on the right forearm and the upper back for the past 8 months. So here it is specifying that there are 3 patches. So please remember, whenever the number is given, there is a reason why they give the number. For the past 8 months, all the lesions are hypoaesthetic to pain and temperature. If these lesions are 3, they are hypoaesthetic to pain and temperature, and only 3 lesions, you know we are dealing with BT leprosy. Examination reveals thickening and tenderness of the right ulnar nerve. This right ulnar nerve also goes in favor of BT leprosy. So overall clinical scenario is BT leprosy. Now the number of skin lesions is 3 and nerve is 1. That's the right ulnar nerve, with no sensory loss in the other limbs. Which of the following is the most appropriate treatment? So when you look at this question, you are seeing that this is a case of BT leprosy, 3 skin lesions, 1 nerve. Where do you classify? Is that a PB type of leprosy, or is that a multibacillary leprosy? You have to tell me what is the classification here. What is your classification of the disease? That is what the question wants to ask us. It wants us to know, it wants us to be able to classify whether it is PB or MB, especially because there was a recent change in this classification. So who will tell me what is the classification? Please remember, this is the recent new criteria for classification, which you might have read in community medicine. We always cover this in dermatology also. For calling it paucibacillary leprosy, the skin lesions have to be either 5 or less than 5. No nerve. Skin smear negative. However, if the skin lesions are more than 5, there is even 1 or more nerves, slit skin smear is positive, then this is MB leprosy. So this is a recent change in guidelines. Now, as per our question, where there are 3 lesions and 1 nerve, where does this fall? If there is even 1 nerve, it falls in the MB category. So please remember, this is a case of MB. Even though the number of lesions is small, but you have to look at the nerve. And when it is MB, you have to give the treatment for 12 months. And what does the treatment include? Once a month rifampicin, once a month clofazimine 300 mg, dapsone continues daily, and clofazimine is 50 mg daily. So this is the treatment that is given, and it is given for 12 months in these patients. Now come to the options. Rifampicin 600 mg, clofazimine 300 mg once a month, dapsone 100 mg, clofazimine 50 mg daily for 6 months. So the dosing is correct, but the duration is 6 months. So this is out. Yahan pe this is correct, and it is given for 12 months. So this is the correct answer. Anything that is 6 months is out. Anything that is 6 months is out. So anyway, all this is out. So what is the correct answer? Correct answer is option B, where the correct dosing. Please here, these are 2 parameters that you have to note. You have to see the dosing, that the dosing has to be correct, and you have to see the duration, that the duration has to be correct. So in option B, both are correct. Remember, you will classify this as MB and treat it accordingly. There might be some confusion across different platforms, across different recall drafts that you achieve, that you read, that you see somewhere on Instagram or wherever. But the classification here is going to be MB leprosy only. Now, the next question, a 4-year-old boy, so this is a small boy, brought to pediatric outpatient department with fever, painful oral ulcers, multiple vesicular eruptions over the palms, soles for the past 2 days. Which of the following is the causative organism? Very expected question, was there in the last few years as well. INI favorite, FMG favorite. So this is a child who has fever, who has oral involvement, and who has vesicles over the hands and the feet. Where does this take you? This takes you to hand, foot, and mouth disease. A very simple one. Is this caused by parvovirus B19? No, that is erythema infectiosum. You will see the slapped cheek appearance. Varicella zoster would cause vesicles, but these vesicles would be all over the body. So this is also out. Herpes simplex virus type 1 will cause herpes labialis. These will be painful oral lesions, but they will not be on the hands and the feet. It is caused by Coxsackie A60. So this is HFMD, very, very important. You get these painful vesicles on the hand, foot, and the mouth. Child can also suffer from fever, loss of appetite, malaise. These are all other features that can be there in the viral illnesses. So the important point was to differentiate it from herpes and varicella here. A 25-year-old sexually active man presents with a painful swelling in the right groin for the past 2 weeks. Physical examination reveals enlarged inguinal lymph nodes, enlarged femoral lymph nodes, separated by the inguinal ligament, producing the characteristic groove sign. Which of the following is the likely causative organism? They have been asking this question repeatedly. It was there in July 25, it was there in January 26, then previously in January 24 also. This has become a recent favorite of the FMGE exam. Tell me, what is the diagnosis here? There is a painful swelling in the groin, which are lymph nodes, which have the groove sign. So the diagnosis here is lymphogranuloma vanillum. Is that done with all of you? Is the diagnosis clear? Yes, it should be clear. Kya or what else it's going to give us? It's giving us painful lymphadenopathy. It is giving us the groove sign. So this is LGV. What causes LGV? LGV is caused by Chlamydia trachomatis L1, L2, L3. So the correct answer here is option C. I don't even need you to eliminate. See, Klebsiella granulomatis was a doubt. A lot of students marked Klebsiella granulomatis, but this causes donovanosis. Donovanosis is a painless ulcer. First of all, it's a ulcer. Second of all, it is painless. Here we have a painful swelling. And donovanosis is the only genital ulcer disease which does not have any lymph node enlargement. So there is no lymphadenopathy in donovanosis. This cannot be the answer. Yes, you see pseudobubo, you may see a pseudogroove sign, but you don't see the painful lymphadenopathy mentioned here in the groove sign. Haemophilus ducreyi causes chancroid, but in chancroid, it is going to be a painful genital ulcer with painful lymphadenopathy. So a genital ulcer with lymphadenopathy would give us chancroid, not this. And treponema pallidum is syphilis, which is a painless ulcer with painless lymph nodes. So all of these are out. The correct answer is option C. Remember the serotypes L1, L2, L3, it causes bubo without any genital ulcer. And the classic sign here is the groove sign of Greenblatt. In question number 28, question here. A 28-year-old sexually active man presents with multiple painless, exophytic, cauliflower-like growths over the genital region, gradually increasing its size over the past 3 months. What is the causative organism? So the question here is, what is the causative organism? Can you tell me what is the causative organism? Is this, what is the diagnosis? First of all, see, it is a painless exophytic cauliflower-like growth. So whenever it is cauliflower-like, this is how it looks like. So this cauliflower-like growth in the genital area are genital warts. These are genital warts, also called as condyloma acuminata. Ducreyi, we have just seen, causes chancroid, out. Treponema pallidum causes syphilis, which is a genital ulcer. It is out. Herpes simplex virus causes herpes genitalis, which is painful vesicles. It is out. The correct answer here is human papilloma virus, which causes genital warts. Clear with everyone? This is a very, very important point. After 2-3 exams, they have actually asked a question on genital warts. They had forgotten it in 2025 and Jan 26. So 3 exams, no questions. but now they have asked. So these are the cauliflower-like growths. All of them will have the rough surface of the cauliflower. This is the condyloma acuminata, most commonly caused by HPV-6. So these are genital warts. With this, we finish our discussion of the dermatology recalls. Any discrepancy, any change in the options or the questions that you see, please feel free to comment or let us know. We'll, draft a proper paper with the recalls, which will be of help to you as well as your juniors who are preparing for the next exams. So all the best. I hope you get the result that you are wanting. See you on the other side of the paper. Thank you. All the best.